all dear my friends.
Good
Today,
evening, Dr. Ajay, and welcome.
Thank you very much, Dr. Priyanka. So we can start our session now. Today's topic is operative vaginal delivery. So the introduction.
Dr. Ajay sir, please unmute yourself. We can't hear you.
Yeah, now?
Yeah, sure.
Yes.
Operative vaginal delivery refers to a delivery in which the operator uses forceps or a vacuum device to assist the mother for the childbirth. The instrument applied to the fetal head, and then the operator uses traction to extract the fetus, typically during a contraction, along with pushing efforts of the mother. During the second stage of the labor, one may require assistance when maternal efforts fail to effect the delivery, or where there are non-assuring FHR patterns. Therefore, the ability to perform an OVD with forceps or vacuum remains a vital skill for those who provide maternity care. In fact, WHO thinks that it is an essential skill for the persons who practice obstetrics. Classification of operative vaginal delivery. Fetal extraction is classified by the status of the fetal head at the time of operative vaginal delivery and the degree of rotation. There are basically 4 types, but here we can describe 3 types of delivery. That is outlet, where fetal scalp is visible without separating the labia. Fetal skull has reached the pelvic floor and fetal head is at or on the perineum. Sagittal suture is in AP or ROA, LOA or OP, occiput posterior position. Rotation does not exceed beyond 45 degrees. Then the low delivery. Leading point of the fetal skull is at station +2 or more and not on the pelvic floor. Without rotation or with rotation, which is 45 degrees or less. With rotation, rotation is more than 45 degrees. Then mid delivery, station is above +2 but head is engaged, that is at ischial spines. This is the classification by American ACOG. Then indications for OVD: fetal distress, non-reassuring FHR
We are
patterns.
unable to see your slides, no?
Okay.
We are unable to, yeah, please.
Yes, sir.
Now?
No,
No?
sir, please. No.
No, sir. No, sir.
Actually, it is getting, I think it is
We are
getting delayed.
unable.
I can see the slide.
But on screen,
You have to share the screen, sir.
I'm sharing the screen. I have shared with Dr. Priya. If it is possible that you can share the slides, then also it is okay.
Yes, sir. I'll try my best. Yes, please, sir.
Until that, I will keep it on.
Yeah.
Okay. The indications for OVD: fetal distress, that is non-reassuring FHR patterns. Ideally, the fetal heart rate is about 120 to 160. It is assumed to be normal. During contraction, the FHS, we can see during the second stage of labor, the FHS goes down below 100 sometimes, but within few seconds, when the contraction is over, we can see that the FHS are increasing rapidly. So if we are seeing that there are non-reassuring FHR patterns on NST, non-stress test machine, or also during FHS monitoring during routine labor care, then we can assume that there is a fetal distress. Then maternal exhaustion.
Sorry to disturb you, sir, but I didn't get your PPTs. Please send PPTs to me.
Yeah.
I will try to share.
Yeah.
him a host. Just select his name and make him a host. He will share.
Okay, okay, sir.
Actually, I am sharing, sir.
Dr.
Ajay,
Ajay,
you are-
now you can share your PPT.
No, sir. I am actually sharing my screen and PPT also. I am. It is visible on my laptop.
No. Now you can share. Now you are a host. Now you can share the PPT.
Okay.
Yes.
Yes.
Okay. Yes. Thank you.
Now you are host and guest also.
Yes, sir. Thank you.
Thank you. Yeah.
So maternal exhaustion. Sometimes it is practiced that whenever the labor pains start, the people start to push the baby, and this causes the maternal exhaustion. Another thing, ideally in my routine practice, I keep the patient hydrated properly. The patient who are referred from government institutes or some PSCs or another centers, they do not administer IV fluid or proper diet to the patient. That is the main thing, that the mother gets exhausted during the labor pains. Prolonged second stage of labor. In primi, if the second stage is prolonged beyond 2 hours, and in multi, if it is prolonged than 1 hour, then it is causing trouble to the fetus or to the mother. To shorten and reduce the adverse effects of second stage of labor in a mother with other medical conditions, like for example, cardiac diseases, hypertensive disorders, myasthenia gravis, spinal cord injury patients, which are at risk of autonomic dysreflexia and proliferative retinopathy. In proliferative retinopathy, already the pressure is increased, so there is chance of retinal hemorrhage. So we have to reduce second stage in such cases. These are examples, but the important thing is that no indication is absolute and it can differ from patient to patient. If the clinician thinks that it is the time for an operative vaginal delivery, then he can opt for the vaginal delivery, that is operative vaginal delivery. That is the choice of the clinician. Contraindications to operative vaginal delivery. Absolute contraindications: non-vertex or bro presentation. Second, unengaged head. In non-vertex or bro presentation, it is unable for us. In non-vertex or bro presentation, it is unable to attach the instrument. That is, we have to get a point or a position to attach the instrument properly. In unengaged head, it is absolutely contraindicated. If there is incomplete cervical dilatation, then also we should not opt operative vaginal delivery. Clinical evidence of cephalopelvic disproportion. If the head is palpable still abdominally and not engaged, then that is an evidence of CPD. Fetal coagulopathy. If there are some bleeding disorders in fetus that are to be suspected, then the operative vaginal delivery should not be conducted. Relative contraindications: unfavorable attitude of the fetal head, that is deflex head. If during PV examination molding has not been occurred and you find that there is palpation of both of the fontanelles easily, then the head is not fully flex. In a fully flexed head, we can easily palpate the posterior fontanelle and with difficulty the anterior fontanelle. So the attitude of the universal attitude of the head is flexion, that should be achieved as soon as the head reaches the pelvic floor. Rotation should be more than 45 degrees from the occiput anterior or the occiput posterior position. Station at mid pelvis and fetal prematurity. These are the contraindications for operative vaginal delivery. Contraindications specially for vacuum delivery. Number one is cephalopelvic disproportion. Another, fetal head is not engaged. Gestational age less than 34 weeks. If the fetus is less than 34 weeks and if we apply ventouse on that, then there is a chance of caput formation, then intracranial hemorrhage. So it is not indicated before 34 weeks. Certain fetal conditions such as fetal bleeding disorders, for example, hemophilia, neonatal alloimmune thrombocytopenia, von Willebrand's disease, and fetal demineralizing disease. Example given, osteogenesis imperfecta, etc., in which we cannot apply or use vacuum. Non-cephalic or face presentation, that is also an contraindication. Prerequisites for operative vaginal delivery. Complete abdominal and careful vaginal examination. This should be the routine practice in our day-to-day obstetrics practice, and we all know that everyone performs this kind of examination frequently, as we taught in our institute. But if we are going to perform an operative vaginal delivery, you should re-examine the patient for the engagement. Then I am getting some noise from Dr. Pradna madam. Careful vaginal examination. Complete abdominal and careful vaginal examination, that is the dilatation of the cervix, then effacement of the cervix, then the position of the vertex, the rotation, and the station. Whether the membranes are present or ruptured, that is also important. Emptying of the maternal bladder. If the maternal bladder is not empty, then it may be harmful for the bladder and it may cause bladder injury, or it may lead to various kind of fistula, that is vesicovaginal fistula. Engagement of fetal head, ruptured membranes, fully dilated cervix, assessment of caput and molding. Caput and molding represent some kind of fetal distress. If the molding is not reversible, then that may indicate CPD or borderline pelvis. Flexion of head, irreducible molding may indicate CPD. Determination of exact position of fetal head for proper placement of the instrument. There are some points, for example, flexion point, where we apply the ventouse. The mother, for the procedure after informed written consent, the mother should be prepared for the procedure after informed written consent. We have to instruct her what we are going to do with her. Adequate anesthesia, regional block is preferred. In the rural areas where I practice, we continue our work or perform our work with local anesthesia only. But in metro cities where the patient is willing for operative vaginal delivery, you can prefer other blocks also. Aseptic technique should be obtained because we are going to perform that vaginal operations for quite longer time than the other normal delivery procedures. So aseptic technique should be maintained. There are emergencies in obstetrics where we apply for operative vaginal delivery. So we have to maintain strict asepsis. Skilled operator and staff required. The person who is conducting the delivery should be very well trained to perform such kind of operations, and also his or her staff should be well acquainted with the procedures of operative vaginal delivery, neonatal resuscitation, and other things if required. Adequate facilities are available. If blood or anesthetics or all these things are required, then that should be kept in hand. Backup plan in case of failure to deliver. Many a times, due to certain conditions, the patient is not cooperating for this kind of procedure because they are painful. If we are not having any anesthesia, proper anesthesia, then the patient doesn't cooperate and we have to opt the cesarean section. And it is observed that the cesarean birth, after such kind of attempts of operative vaginal delivery, that is forceps delivery or induced delivery, the baby comes out in jeopardy. So neonatal resuscitation is required at most times. So forceps, this is the structure of the forceps. This is the toe. This is pelvic curve, and the another side is cephalic curve. This is the fenestration. Some forceps are solid, but this is the fenestrated forceps. Toe, curve, and heel. These constitute the blade. The part which connects the handle and the blade is called as the shank. This is the lock. As there are two parts of the blade, centrally there is a placement to attach these parts, that is called as lock, and this is the handle to hold the forceps. Blades grabs the fetus. Each blade has a curve to fit around the fetus, that is cephalic curve. The blades are oval or elliptical and can be fenestrated with a hole in the middle or solid. Many blades are also curved in a plane 90 degrees from the cephalic curve to fit the maternal pelvis, that is pelvic curve. Shanks. Shanks connect the blades to the handles and provide the length of the device. They are either parallel or crossing. These are the types of the shanks, that is cross, divergent, parallel, or convergent. Lock. There are 4 types of lock. Lock is the articulation between the shanks. Many different types have been designed. This is the French lock. This is the German lock, English lock, sliding lock. Handles. The handles are where the operator holds the device and applies traction to the fetal head. Types of forceps. More than 700 types of obstetric forceps have been described. Each of the 3 main types, that is outlet, mid-cavity, or rotational forceps, is appropriate for the specific situations and require differing levels of expertise. Nowadays, outlet forceps are to be routinely applied, and mid-cavity and rotational forceps are extinct nowadays. Classical instruments originally designed by James Ian Simpson, Wrigley and George L. Elliott Jr. in the mid-19th century. They are used for outlet and low pelvic rotational delivery. These are the classical instruments, Simpson forceps and Wrigley forceps. Specialized instruments designed for specific indications like number 1, Killand's forceps for mid-pelvic rotation and correction of asynclitism. Asynclitism, that is deflex vertex. Piper's forceps for delivery of aftercoming head in the breech. It is a slender forceps having long blades, and it is applied for the aftercoming head in the breech delivery. Lopez forceps with divergent or parallel blades, so designed to limit fetal cranial compression, especially in preterm labor patients. Barnes, Neville and Haig, Ferguson's forceps for axis traction. There are some images of Killand forceps, Piper forceps, Lopez forceps, Barnes, Neville and Haig Ferguson. They are having axis traction device here. Types of application of forceps blade. Number 1, cephalic application. When we apply the blades according to the head of the fetus, then it is called as cephalic application. So the long axis of the blades correspond to the occipitomental position and the ends of the blades line over the posterior cheeks. The sagittal sutures of the fetal head will be in the middle and the blades will be equidistant from the sagittal and occipital sutures. At no times should any part of the forceps cover any midline structure. Forceps should not be applied to the midline of the any structure. They should be applied on the sides of the head of the fetus. Another test, confirmatory test that forceps are applied properly is that the forceps should lock easily without any force and stand parallel to the plane of the floor. The appropriateness of the application should be confirmed before applying traction. The correct cephalic application is with the head in the occiput anterior position. Another one is pelvic application, where we do not think about the fetal head and the forceps are applied along the lateral pelvic walls. The most crucial point of forceps delivery is precise knowledge of the presentation position of the fetus. The term pelvic application used when the left blade is applied on the left side of the pelvis and the right blade is on the right side of the pelvis, regardless of the fetal position. A pelvic application may be appropriate in some instances as in direct occiput posterior presentation, but pelvic application is never to be used as a substitute for the exact knowledge of the fetal position. Inappropriate pelvic application may cause significant harm. Serious compression effect on the cranium can occur, so it should be avoided. When the head is sufficiently rotated, pelvic and cephalic application naturally coincide. So rotation of the fetal head is the most important thing in applying the forceps. If you are doubtful about the rotation in case of molding or caput formation, then do not opt operative vaginal delivery or forceps delivery. So here the proper application of the forceps, low forceps, has been shown. Functions of forceps, how forceps work. Traction. This is the most important function of the forceps. Pull required in a primary gravida is around 18 kg and multiplied in 13 kg. Compression effect. This is minimal when properly applied and should not be more than necessary to grab the head. The compression should be just like that. Only minimal force is to be applied on the during the traction and on the fetal head. However, it has some pressure effect on the head and the well-ossified base of the skull. Rotation of the head. This occurs with the use of Killand forceps and also in low forceps with cephalic application with the occiput in the +2 or 10 o'clock position. Protective cage. When applied on a premature baby, it protects from the pressure of the birth canal. When applied on the aftercoming head, it lessens the sudden decompression effect. As a vectis, by applying one blade to deliver the head in cesarean section. Traction with forceps. During a forceps delivery, traction is applied during contractions. It is important thing that the traction should be applied during only contractions. The instrument may be used to maintain the station of the fetal head between the contractions. Sometimes we can see that the fetal head comes down, descends down with the contraction, and sometimes it goes upwards. It happens when there are cord around neck, loops of cords around neck. So here we can use the forceps to maintain the station of the fetal head between the contractions. In an emergency, applying continuous traction may be necessary until fetal head delivers. In the last stage, where without contraction, we can also gradually apply some force to deliver the fetal head. After confirming proper forceps application, traction starts parallel to the plane of horizon. First, we have to apply some pressure in horizontal direction, and then gradually to the almost vertical position. We have to mention the axis of the birth canal, so we can have the safe fetal head descent. The angle of traction is important as the force applied in effecting delivery. Knowing when to stop and abandon the procedure is a matter of experience. So there is no criteria to describe here that when to stop. It is the skill and judgment of the operator to decide we have to go for the operative delivery or we have to go for cesarean section. Assuming that everything has been done according to proper protocols and no progress is observable in 3 traction attempts, 3 traction attempts are failed, then the operative vaginal delivery should be discontinued and preparation for emergency LSCS should be started immediately. Rather, I would like to say that you should perform the operative vaginal delivery starting with all the necessary preparation for cesarean delivery. Anesthetic should be ready, and if there is a chance of operative vaginal delivery, then it should be performed into the OT itself. And if your 3 attempts fail, then immediately you can start the cesarean section. So here is the traction in a parallel direction, then downward, then backward, and then upward direction until the jaw reaches here. These are the A, B, C, D, E, F, G, H, I, J mnemonic for the forceps. A, address the patient, ask for help, adequate anesthesia. B, the bladder should be empty. C, the cervix should be fully dilated. D, determine the position of the head. E, equipment should be ready or forceps should be in a ready condition. F, forceps applied. G, gentle traction. H, handles are elevated to follow the J-shaped pelvic curve. I, evaluate for incision for episiotomy when the perineum distends. J, remove the forceps when the jaw is reachable. Technique of outlet forceps. Number 1, identification of the blades and their application. The instrument should be placed in front of the pelvis. I will show a video where I have shown all these things. The instrument should be placed in front of the pelvis with the tip pointing upwards and the pelvic curve forwards. First, the left blade should be applied, guided by the right hand, then the right blade with the left hand. Locking of the blades. The blade should articulate with ease, indicating correct application. If the forceps is not applied properly, then the locking will not happen. And if you are going to apply some pressure, then the baby will pay for it. Clinical checks for correct forceps application. Sagittal suture lies in the midline of the shanks. The operator is unable to place more than a fingertip between the fenestration of the blade and the fetal head on either side. Posterior fontanelle is not more than 1 finger breadth above the plane of the shanks of the forceps. Outlet forceps technique. Traction. Steady and intermittent traction to be applied during contraction. First downwards, backwards, forwards, and lastly upwards. Outlet forceps, only 2 fingers are to be introduced. Traction is applied straight horizontal upward and then forwards. Removal of blade. Right blade should be removed first. In occipito-posterior position, blades are to be applied as usual, but they should be equidistant from sinciput and occiput. That is the difference. Traction. Horizontal to the root of the nose is under the pubic symphysis. Then upwards till the occiput emerges over the perineum and finally downwards. This is the easiest and often the best method for an infant in the direct occiput posterior position. If the head is low in the pelvis, it is likely to be deliverable with a very little traction and the fetus is spared the risk of manipulation. So, in these images, we can see here the forceps. So, this is the first application of left blade, application of the right blade. In this image, the blade has been applied appropriately and gradual traction is given. Here, episiotomy and traction. So here is one of the video.
Dr. Ajay, audio is not there. Dr. Ajay?
Yeah, I am actually having audio.
Rotate the screen also.
Whether it is audible now?
Your
Not
voice is
audible yet.
audible.
No, sir.
Video particular is not.
Okay. Actually, I will explain if it is not because I am getting the audio. There is some kind of problem. Okay.
Yeah. Okay, no problem. But rotate the screen particular.
I'm not seeing that option here for the screen rotation.
Just now you did, sir. A few minutes back, you rotated the screen. Just try it once again, sir.
Yeah. All right. No, option is not here. Okay.
Okay.
So here I'm explaining the mnemonics again. A, B, C, D, E, F, G, H, I, J. That is the mnemonics. The scalp is visible and occiput anterior position is there. The rotation should not exceed beyond 45 degrees on the right or the left. Our equipment should be ready. Forceps is ready. Episiotomy is required in forceps. A big episiotomy is required. We have to identify the blades at first. This is the left blade and this is the right blade. Now we are going to apply the left blade first. So the tip should be towards the sky. With the help of the two fingers of the right hand, gently apply the blade to the scalp of the fetus. Ask your assistant to hold the blade. Then the another blade in the similar manner on the right side. You have applied both the blades. Just check once for the position. Now the traction. Downwards, backwards, horizontal, and then upwards until the jaw reaches the perineum. Remove the first blade first, that is the right blade. Left blade. So here I have shown it on a coconut. I learned and tried many times forceps delivery on coconut first, and then I applied it on the fetal head actually. So the another point is trial of forceps. Knowing that a certain degree of disproportionate mid pelvis may take the procedure incompatible, low or mid forceps delivery is attempted, abandoning it at the earliest in favor of cesarean section. So it should be done only in the operation theater, keeping everything ready for cesarean section. Failed forceps. When an unsuccessful attempt is made with the forceps, resulting in fetal and or maternal injury, mostly is due to lack of the obstetric skill and poor clinical judgment, and not due to the instrument. Factors which are responsible for failed forceps are disproportion, that is speeding, incomplete cervical dilatation, and malposition of the fetal head. Outcome and prognosis. The ultimate outcome of forceps delivery depends upon numerous factors. Most important is the skill and judgment of the operator. The operator must be supported by a skilled team, including anesthesia and nursing staff. The presence of a person skilled in newborn resuscitation is also mandatory for operative vaginal deliveries. Complications. Complications of forceps delivery are mostly due to faulty technique rather than the instrument. Maternal complications, injury, extension of the episiotomy involving anus and rectum or vaginal vault, vaginal lacerations and cervical tear if cervix was not fully dilated. Postpartum hemorrhage due to trauma, atonic uterus or anesthetic complications. Sorry, PPH due to trauma, atonic uterus or anesthetic complications. Shock due to blood loss, dehydration or prolonged labor. Sepsis due to improper aseptic care or devitalization of local tissues. There is possibility of sepsis. Anesthetic hazards. Then delayed or long-term sequelae, that is chronic low backache, genital prolapse, stress incontinence, anal sphincter dysfunction. We can see in many post-operative vaginal delivery patients that these type of complications may occur. The frequent complications are anal sphincter dysfunction and chronic low backache. Fetal complications: birth asphyxia, trauma, intracranial hemorrhage, cephalic hematoma, facial or brachial palsy, injury to the soft tissues of face and forehead, skull fracture. These are the immediate complications, and the remote complications are cerebral palsy. In some patients, the fetal death may occur, and the percentage around 2%. Our next topic is vacuum or ventouse delivery. Maelstrom device vacuum with a ring, rigid metal cup, and a separate suction catheter. We can see here, this is the ring, and there is separate suction catheter attached laterally and connected to a foot operated pedal. This was the prime device. So types of the vacuum device: rigid or metal, that is Maelstrom, bird, and other modifications. Celastic, Kobayashi, plastic, bell, mushroom, and soft. Modern day vacuum cups can be soft or rigid and can be different shapes and sizes. In routine day-to-day practice, there is small, medium, and large size of vacuum cups. These may be anterior or posterior cups. Posterior cups have been designed for occiput posterior and asynclitic deliveries. Newer devices comes with or without separate suction device. They are disposable. So we can see here newer vacuum cup devices. Here the electric machine or suction is not required. One can operate it easily. This is Kiwi Omni Cup, a rigid plastic cup that is disc shaped and modeled after the original bird posterior cup. This is suitable for occiput posterior deliveries. There is a hand pump suction here. We have to attach the tube here, and this suction cup doesn't require a tube. 𝐴𝐵𝐶𝐷𝐸𝐹 mnemonic for vacuum, slide 1. As we have seen in forceps delivery, in vacuum delivery also, we have to instruct the patient and discuss the risk and benefits of operative vaginal delivery. Assistant should be on hand for delivery of and for neonatal resuscitation, and should be made aware that the use of the instruments, how they are used, what is to be done, another steps, because they are used to have normal deliveries and cesarean sections and all other procedures. But where there is a game of life and death, that is operative vaginal delivery, the operator should be courageous and the staff should be having knowledge and also confident. Analgesic should be administered if needed. Bladder should be emptied. Cervix, it should be fully dilated, and we have to determine the position of the head before applying the ventouse. Equipment should be checked to ensure the vacuum and adequate suction. We must follow this step. Sometimes we apply the vacuum and our suction doesn't work or doesn't have adequate pressure. So it should be checked. Flexion point. The flexion point is a point which is 3 cm away from the occiput and around 6 cm away from the sinciput, and where we can attach the vacuum cup and we can apply a maximum traction, and there is a minimum chance of detachment of the cup. That is flexion point. Gentle traction should be given. Suction with the manometer is to be monitored, and gentle traction at right angle to the plane of the cup during contraction is applied in the initial phase. 3 disengagements of the vacuum or pop-offs Then if we are going to apply the vacuum for more than 20 minutes, then we should stop our procedure after 3 consecutive pulls, which result in no progress of the delivery. Incision for episiotomy. Previously, it was recommended, but nowadays, during vacuum delivery, episiotomy is not routinely emphasized. The operator can decide according to the rigidity of the perineum. Remove the vacuum when the fetal jaw has been reached. So, here we are demonstrated. The vacuum is applied and there is no contraction. During contraction, with the push-ups of the mother, gentle traction in horizontal direction, and then according to the axis of the birth canal, and as soon as jaw has been reached, the cup has been removed. Complications: maternal risk, lesser maternal soft tissue trauma than the forceps delivery, less general and regional anesthesia. However, vacuum extraction was more likely than forceps deliveries to fail. So vacuum fails and forceps doesn't, then the vacuum delivery. Neonatal cephalohematoma, which may turn into hyperbilirubinemia. Retinal hemorrhage, it usually resolves within 4 weeks. Shoulder dystocia, rare but serious intracranial hemorrhage and subgaleal or subaponeurotic hematoma and death. Signs and symptoms of serious intracranial injury in a neonate. How to diagnose that we have done something wrong with the fetus? Intracranial hemorrhage, apnea, bradycardia, bulging fontanelle, convulsions, irritability, lethargy, and poor feeding. All these signs may indicate intracranial hemorrhage. Subgaleal hematoma, diffuse head swelling that shifts with repositioning and indents on palpation. Signs of hypovolemic shock, that is hypotension, pallor, tachycardia, tachypnea. Swelling not limited by suture lines, unlike cephalohematoma. Cephalohematoma is limited by suture lines, but subgaleal hematoma is seen beyond the suture lines also. These may not appear until several hours after birth, so we have to carefully monitor the baby in the postpartum period. Here also the video.
Sir, audio is not there.
My audio. I have to again explain it. We are going to see whether the pressure is increasing or not. So we have to check the pressure. Here is our vacuum suction cup. It is made up of celastic material. There is tip to attach the suction tube, and there is a handle to hold. Here we are going to check the pressure on hands. We can see the pressure is increasing. Now we are going to apply the vacuum at the flexion point. The cup should be applied when there is no contraction. If there is an increased pressure, so we can release with the help of this knob the excessive pressure. We have to see whether the cervix has not caught into the cup or any other skin or anything else. Gradually we have to apply the pressure in the horizontal and then in the upward direction. As soon as the vertex reaches the perineum, you can either release the pressure or remove the suction tube. Sorry for the trouble. So post-delivery care, it is also an important part. Assessment of the mother, vitals, then the uterine action, PPH, any lacerations, thromboprophylaxis if necessary in cases if the patient is obese or having complications, other medical conditions or PIH. Then oral anti-inflammatory and antipyretics in the absence of the contraindications. First, wide urine timings should be noted carefully. The volume of the urine and post-wide residue in case of retention of urine. Urinary incontinence. If we observe any kind of urinary incontinence, if there is chance of urinary incontinence, then postpartum physiotherapy for prevention and cure of the urinary incontinence. Counseling regarding contraception and future pregnancies. Tocophobia. There is a term known as tocophobia in which the people experience the fear of future childbirth. In Ayurvedic texts also, you can see the reference of 𝙎𝙼𝙎𝙀. In Garbhasanga, Yoni Samvaran or Mudgarbha in Vagbhat Samhita, there is 𝙎𝙼𝙎𝙀 described for the delivery of the baby. If the 𝙎𝙼𝙎𝙀 fails, then we have to deliver the baby by 𝙈𝙼𝙃𝑉𝑖𝑦 process. So this was all about operative vaginal delivery. I think I have covered all of the points. Thank you very much for your patient listening.
Thank you so much, sir, for your wonderful lecture. You have explained it very well.
Thank you very much, Dr. Priya.
Yes, sir. Moving to the next session, we will take question and answer, sir.
Yeah.
For this, I would like to call Dr. Shashi Wankhede, sir. Sir, please, you can conduct the question and answer session.
Yeah.
Okay. Thank you, Dr. Priya. Thank you, Dr. Ajay,
Thank you,
for
sir.
explaining thoroughly the topic. You have explained all the practical aspect of OVD. Now here is a question and answer session. I don't think there is any doubt, but some of question in my mind, simple questions.
Okay, sir.
One of it is if there is a cord around neck to the baby,
Yeah.
we can see nowadays in USG report, it is mentioned that last trimester report, it is mentioned that there is a cord around neck, and the situation is indicating for the OVD. Then what is the what would be the better option, OVD or the straight to the LSCS?
See, here whenever there is cord around neck, then we can see during labor the progress is slower sometimes, the descent is slow, and in second stage of labor there is a non-reassuring FHR pattern. If you are observing that there is non-reassuring FHR pattern, but the descent is good and the head is on perineum, and there is no chance of outlet CPD, then you can deliver the baby as usual with the operative vaginal that is the forceps or vacuum, whichever you are comfortable with. But if acute very severe fetal distress is there or meconium strain liquor is there, then I would not like to opt for the vacuum or forceps, and I will opt the cesarean section. Cord around neck is seen many times during routine sonographic scans, but I have observed that if we opt cesarean section with indicating in the report only, then sometimes it is not seen. I have done cesarean section of one patient with indication of 2 loops of cord around neck, and after exploring, I saw no cord. So that happened in past. Nowadays there are color Doppler ultrasounds and they can accurately diagnose the conditions. But the fetal weight is adequate, the size of the baby is adequate, and there is no CPD, then you can go for vaginal delivery with the help of the instruments.
Very nice, sir. Very nice, sir.
Thank you.
Another
Thank
question,
you so much, sir. I have one question.
Okay.
Yeah.
Just,
I have one.
let it, ma'am. Let us finish the question,
sorry, sir.
and then I will go
Sure,
to the
you please
participant.
continue.
Sir,
Okay.
one simple question we all observe or we all experience during the labor, though it is not mentioned in the book also, that giving fundal pressure in the second stage can also be called as operative vaginal delivery or assisted technique for the vaginal delivery.
That is an assisted technique. You are completed.
Yes.
You can ask your question further.
Sir, what is your remark for fundal pressure?
I think fundal pressure should be given when the mother is seen to be exhausted, or only 1 or 2 fundal pressures are to be given during the contractions. But you cannot give fundal pressure for 15 minutes, 20 minutes, or half an hour, because the uterus itself gets exhausted, and the chances of PPH are increased in such kind of cases. So fundal pressure should be given only 1 or 2 times or 3 times during the last stage, and it should be mentioned as a part of an assisted delivery and not as operative delivery. So there are only 2 kinds of operative delivery, that is forceps or vacuum.
Okay, thank you, sir. I think the participant may ask the question. Who are asking?
Ask the question, or they can post in chat box also.
Yes, you may post the questions in chat box. I can read it for you.
Sir, one question from my side. You mentioned that forceps needs traction in multigravida 13 kg and in priming gravida like 18 kgs. But if we are manually pulling it, if we are manually keeping the force, so how can we measure the force in kgs, sir? I mean, is it measurable by a human being? I mean,
no. Actually, it has been given in the studies, or that is our reference range. As I have stated earlier, that is the thing which is to be carried by skill and judgment only. So how much pressure is required is a matter of the operator. In other text, it has been given as kilogram centimeter square also. Then mm of Hg, that is 400 to 650 mm of Hg. So that is not easy to calculate, but the force should be applied in such a way that easy delivery is to be facilitated, and no such kind of force is to be applied that may harm the fetal skull or the maternal tissue. So that is a matter of anticipation.
Okay, sir. Thank you so much.
Yes.
I'm saying,
Sorry.
Dr.
One
Shashi,
question.
can you read it, sir?
One question is came from Dr. Sujata. In case of FGR with normal Doppler study, can we give trial for normal delivery? In case
What
of
is FGR? What is meant by FGR? I don't understand.
Fetal growth retardation.
Fetal
Okay.
growth retardation.
In case of FGR with normal Doppler study, can we give trial for the normal delivery?
Yeah. Yeah, we can give trial for normal delivery. If NST is operative vaginal rehab, if NST is good, then we can try for forceps. We can apply forceps in preterm birth also. So in a full term IUGR patients, we can apply forceps if the all other conditions are favorable. If there is no mucinous stain liquor, if the labor progress is smooth, then we can opt operative vaginal delivery. Rather, it is good. IUGR is not an absolute indication for cesarean section. There are only 5 absolute indications of cesarean section, as we all know it.
Okay, very nice, sir. Any other question? You may send to chat box, or you can ask directly.
So one more question, can I ask?
Yeah,
Yes,
sure.
yes, please.
Yes. So, in which medical condition in pregnancy we need to cut short the second stage of labor, sir?
As we have seen earlier, the medical conditions, that is the some cardiac diseases, myasthenia gravis, or in some conditions like the maternal exhaustion is seen, then we have to cut short the second stage of labor. And fetal conditions also, if there is non-assuring FHR or there is a delayed descent, then we can have this kind of operative vaginal deliveries in that patients.
Okay. And if we want to cut short the second stage of labor, and if cervix is not fully dilated, in that case, what to do, sir?
We can use some drugs like dotaverine, which are smooth muscle relaxants. We can manually strip the cervix. We can rupture the bag of waters if it is not ruptured. But the basic thing is that if the fetal head is engaged and there is one term which is known as tubular cervix or hanging cervix. If the pressure of the head is not applied properly on the cervix, then it is called as hanging cervix. And in such cases, in spite of good contractions, the cervix doesn't get fully dilated.
Okay. So is there any such thing like we can take cut on the cervical area also, or on cervix? Can we do take a cut?
Some people in the past used to practice like that, but if the tear goes upwards, there is a huge blood supply from cervical artery, then uterine artery, then again ovarian artery to the uterus and all these things. So if
there are high chances for that in that condition for the PPH. Yeah.
So if you are well skilled, you have good assistant, and then you can able to find the apex of the cervix or the tear, you can suture it. Then you can opt that also. But
Okay,
it is a matter of very medical legal problems or any other problems related with the patient.
Yes, sir. Definitely, sir. Thank you so much.
Yeah. Dr. Priyanka, ma'am.
Hello, Ajay.
Hi, I would like to, if you share some of your thoughts about OVD.
Yeah, it was a nice presentation and very simplified, very simplified. And I think that may even beneficial for our PG students also who are recently joined in our group. And regarding your presentation, I think there are you have covered all the things, probably the indications, contraindications, requisites for for instrumental delivery. So I think a very nice presentation by you.
Thank you. I would share that videos which were not visible or audible in the session on our group.
That you can share in the group also. So it will be good for all. And, Priya, if you have any questions, again, Dr. Shashi.
Dr. Manisha Devkate is saying nice presentation, Dr. Ajay.
Thank you, madam.
Sir, we have a better modality like LSCS, then why one should go for the assisted labor, sir? I mean, that is a more safe practice like LSCS. Many people are avoiding to apply forceps and ventus in normal, in private practices. Then what is the importance of it and why should one apply the forceps or ventus?
Very good question. As I have stated, I am working in rural area of Konkan, where anesthetics are very sparse. So we have to inform the patients in labor as soon as it comes to our hospital. We have to inform the anesthetic, sir, there is one labor patient which I ordered. And then anesthetic ask, अरे यार फिर ले लो उसको जल्दी ले लो मुझे जाना है इधर कॉल है तो ऐसा होता है कभी कभी. So sometimes if I feel that the patient may get to be delivered vaginally, then I used to not to inform the anesthetic earlier, because मैं जैसे कहा है वो कहते हैं कि आप जल्दी ले लो फिर उसको टाइम है तो क्यों रिस्क लेते हो, ऐसा होता है sometimes. So if the anesthetic is not present in time and if there is some condition just like non-reassuring FHR, so we should have this skill. I do not say that you should not opt LSCS, but LSCS is luxury in our area. So if you are practicing in such area or due to any kind, any problem, if the anesthetic is not available on time, so this skill is essential for yourself in case of an emergency. आपने लाइव बच्चा निकाला है, बाद में उसका न्यूनेट NICU में शिफ्ट हो गया है, कहीं होगा, ये बात अलग होती है. लेकिन अगर आपके पास मैटरनल डेथ या फिटल डेथ होता है तो आपके करियर का सवाल होता है. ऐसे वक्त आपको ऑपरेटिव वजाइनल डिलीवरी इज मस्ट. तो बच्चे को लाइव निकालो, उसको NICU में शिफ्ट करो, माइनर कुछ प्रॉब्लम से वो रिजॉल्व हो जाते हैं, जो भी कॉम्प्लिकेशन बताए, हाइपरबिलिरुबिनेमिया है या फिर और कोई है, उसमें से कुछ कंडीशंस ऐसी वो रिजॉल्व हो सकती है. अगर किसी कारणवश आप LSCS विद इन टाइम नहीं कर पाए तो आपको जो हार्म हो सकता है वो बियॉन्ड लिमिटेशंस है. इसीलिए आपको ये स्किल आना चाहिए. LSCS तो प्रेफर्ड है ही, उसके बारे में तो कोई दिक्कत ही नहीं है, मगर ये स्किल हासिल करने के लिए मैंने खुद बहुत मेहनत किया है. फोर्सेप्स के लिए हमें ये इंस्टीट्यूट में सिखाया नहीं गया था, हमने खुद होके सिखाया. तो मैं ऐसा चाहता हूँ कि जो आने वाली जो जनरेशन है वो भी इसको सीखना चाहिए.
Actually, Priya, this job is very tough and very it requires a very good skill. And Dr. Ajay, I think he is one of them like that who is performing in a rural area where such conditions are very frequent, not getting anesthetics and other facilities. So in that condition, what the best of can a gynecologist do for the patient? So that these skills are should be developed and should be practiced in our institutional levels also. So
definitely, ma'am. But
I think
whenever
he is doing a very good job. I really admire him for this because as per the limits he has, and he is doing a very confidentially, very doing all these operative vaginal deliveries. Even when I ask him for this lecture. He was just had done one forceps delivery before the day before I asked him for this webinar. Hannah?
Yes, yes.
It's really commendable, sir, because when we used to practice at civil hospital also, there even forceps was it was totally banned, and no one was using forceps even at civil hospital also. So no one is using forceps nowadays. So you are one of the rare rare people, sir.
I know that
one of the rare and one of the dead.
Yeah.
as we
definitely
all know,
it needs a huge daring, sir.
Yeah. As we all know that we
And
are
still,
Ayush
I think very down to earth personality and such a social one, very friendly, and I think he has a lot of guts in this skill. People should learn from this, PGs and other students also in the faculties, that mental delivery is very difficult to handle, and it can be achieved unless and until you practice it and experienced it in your routine daily practice.
Yes, definitely, ma'am. Sir, one more question I wanted to ask. You've shown us a video of vacuum extraction.
Yes.
In that you used that vacuum suction machine. Even we use that machine in our hospital. But how to measure the pressure by applying this much? I mean, that vacuum machine create too much pressure. So how to control it through the
There is a
how
knob.
to control the pressure. Yeah.
There is a knob. There are two knobs. One on the vacuum machine also. You can adjust the pressure from 15 to 20. That is sufficient. In some cases, you can require up to 25 also. It is calibrated from 0 to 30. So the pressure should be around 15 to 20. If you see that pressure is going to increase, or the machine is not calibrated, or the screw, there is one kind of knob placed at the zero side of that manometer, and we can adjust the pressure with that knob. If you see the machine, you will see that. And also the vacuum has a knob. I have shown in that video also. I will put that videos in our group to see it, because today we were unable to hear and see it. I have mentioned in that video. But you can adjust the pressure both on the machine also and on the vacuum cup also.
Okay, sir.
Okay.
Thank you so much, sir.
Thank you.
Anyone from the... Yes, sir.
And Ajay, my request for you, if you got some cases like that.
Yeah. Hello. Okay.
Yes, ma'am, you are audible. Please continue. You are audible.
As soon as I'm
requesting you, Ajay, if you found some patients, at that time, please record that video for us.
Definitely.
Dr. Shashi, sir.
Yes. All the points are discussed very clean and clearly by Dr. Ajay. Dr. Priya, I think you may proceed for the vote of thanks.
Okay, definitely. Thank you so much, sir. We had a very wonderful lecture by Dr. 𝙎𝙖𝙎𝙎, sir. Here we are moving to the last session of this webinar. Special and last thing, vote of thanks. On behalf of NIMA-OBGY Society Central and NIMA-OBGY Society Maharashtra, I would like to express my gratitude to NIMA Central, NIMA Central President, Dr. Vinayak Temburnikar, sir, Secretary, Dr. Ashutosh Kulkarni, sir, and Treasurer, Dr. U.S. Pandey, sir, for their remarkable support to form NIMA-OBGY body. I extend my gratitude to our Central President, Dr. Kamini Dhiman, ma'am, Secretary, Dr. Priyanka Nakade, ma'am, and Treasurer, Dr. Vishnu Bhavne, sir, for supporting and guiding us to conduct today's webinar. I would also like to thank and extend my gratitude to our eminent speaker, Dr. 𝙎𝙖𝙎𝙎, sir, who took time from their busy schedule and delivered a very knowledgeable and wonderful session. I would like to further extend my gratitude to the NIMA-OBGY Maharashtra President, Dr. Suhas Herlikar, sir, Secretary Dr. Manoj Gaikwad sir, Treasurer Dr. 𝙎𝙎𝙎𝙁𝙎 sir, for all their support and conduct today's webinar. I would also like to thank all the help and technical support required for the smooth and interrupted functioning of the webinar. Last but not the least, I would like to thank from bottom of my heart all the delegates from their participants for their participation and presence. Without them, it would have not possible to conduct this webinar. Now, with due permission from all the dignitaries, I am conducting today's vote of thanks, and I take your permission to close this ceremony.
Yeah, Priya, this is our last webinar of this year. I think we will be with the new subjects and with our other webinars in next year. So all of you keep in touch with this webinar series. And yes, of course, now we can conclude, Dr. Priya. Thank you,
Yes,
Dr. Rajmay, for being with us today.
Thank you, all of you.
Thank you so much, everyone. Let's meet in next year with the new topic.
Yes.
Okay.
Yeah.
Bye.
Okay. Thank you, sir.
you all.
Yeah.
Thank you so much.